sure that we have shared responsibility, that it's not your patient or my patient, or not your client or my client, but that it's our client, and that the client is part of that group and has a say in what they want to do. So from all of this, there were 3 governance models. Well, there are many more than that actually developed. But the governance model that was chosen by the Southeast Land Board and put forth as a working model for the future state plan, in which we're going to explore the implications of this model, is option 2. And option 2 includes 3 or so geographic AMH entities. And each of these entities would offer a common basket of service for hospital and contracting, for hospital acute services and specialty or niche services. So that's where we see right now the working model for option 2. And obviously this will be shaped by the work of all of your teams. And in response to requests from the field and to advance the work of the future state planning team, so this came from a lot of conversations and discussions with our stakeholders, a working model for option 2 was developed by the Southeast Land staff and then put forward to you. So that was in our board package and received by all of your agencies last week. So the option 2 working model, what are the parameters of what this actually means? So health service providers identified for amalgamation to form an addictions and mental health entity. So this is when we're talking about what does this actually look like, or what could this actually look like on the ground. So HSPs, in this case, that would be offering a common basket of services. And then services that would be identified to be contracted, what would those look like? So acute hospital services requiring a hospital premises, such as a Schedule I facility. Those really can't be moved out of a hospital site. And defining unique populations. We've got a lot of questions. Well, what makes a unique population? What makes a service unique? And so how we identified that was that it would be regional in coverage, is that it would require specialized or a scarce resource to support, a narrowly defined population, so very small, that will require this service, as well as if it would be the LIN-funded portion of the service would be very, very small. So that's how you define a specialized or a niche or unique population or service. So then the third is that the funding of related services identified to be transferred to the addictions and mental health entities. Services currently within hospital accountability agreements, but are not part of a Schedule I facility, such as other vote or community programs. So what does other vote mean? I actually have that question myself. So that means that programs and services that are funded from a specific chain of funding from the ministry that have a specialized course of funding. So that's kind of what an other vote means. As well as services that should be reasonably part of a common basket for each addictions and mental health entity, or where the LIN-funded services are only a small aspect of an organization's mandate. So then all of that turns into a picture such as this. And it's a little bit hard to read, a little bit fuzzy. However, we are going to send you an electronic version after, and it is posted on our website as well. So what does this mean? So I'm going to pop up here just so you can, I can point to it a little bit better. So entity number 1, and this would be the working model. So definitely we're going to look at this and discuss it. The governance team is going to look at this and have conversations and recommendations about it. But what could this look like? So in Hastings Prince Edward, the first entity. So this would be in the blue. So the blue would be the actual addictions and mental health entity for the Hastings Prince Edward sector. So who would be amalgamated? So this would be mental health services, Hastings Prince Edward, and the Addiction Center of Hastings Prince Edward, as well as what services or funding would be transferred. So at Quinte Healthcare, community programs and other vote programs would be transferred into the actual entity. They would become part of the common basket of service for everyone to access. And what kind of services would be contracted? So here we see the QHC Schedule I, so that's the hospital-based services that we talked about that couldn't be moved out, as well as Sexual Assault Center and Youth Rehabilitation. Sexual Assault Center and Youth Rehabilitation offer very specialized niche services for youth and sexual assault victims. So then we move into Kingston, Frontenac, Lennox, and Addington, Entity 2. And in this case, the 2 agencies that will be amalgamated Frontenac Community Mental Health and Addiction Services, as well as Lennox and Addington Addictions Community Mental Health Services. And the services and funding that will be transferred will be Providence Care community programs and other vote programs. So they would belong to the broader entity, which is labeled in blue. And then what would be contracted? So the Kingston General Hospital Schedule 1, the hospital facility, Hotel D Specialty Hospital Services, Sexual Assault Center of Kingston and KFLNA, Providence Care Specialty Hospital Services, as well as Salvation Army Harbor Light Center. And so finally, Lanark, Leeds, and Grenville, entity 3. So the amalgamated agencies could be TriCAS, could be Leeds, Grenville Mental Health Services, Rock Cottage and Tenant House, and then the services that would be transferred would be the Brockville General Hospital Community and Other Vote, Canadian Mental Health Association Services, funded by the LIN, Developmental Disability Services of Leeds and Grenville Services, funded by us, as well as Perth Smith Falls District Hospital or Lanark Community Mental Health Services. And then the contracted services would again be Brockville General Hospital scheduled facilities. So down from there. And so that is just an overview of what a working model could look like. This is where we're going to start having discussions, and this is where we have our platform to work from. And the governance model is going to take a very careful look at what we propose. So from that, I'm going to pass it over to Sherry.
Jennifer, what I'd like to do is I'd like to just go back one slide, back to the picture that you cannot see if your eyes are on from there. But Jennifer mentioned that was presented at a board meeting and is on our website, so you will hopefully have a chance to look at it a little more closely, and it will be up to you this evening. But I just wanted to stop here for a minute and reflect on a couple of points. So Jennifer talked about this is a working model. We have to start somewhere to generate the discussion. And we used the parameters on the previous slide to help identify that. So a different set of parameters would result in a different working model. So that's part of the discussion, particularly, for each of the teams, but particularly for the governance team, to take a look at what are in these baskets, and as well for the operational team and the admin and finance team in particular, because having an HPE entity responsible for a certain set of services doesn't mean that all those services have to be in the same building. Right? So one of the parameters that we're looking at is making sure that the services are where the people are and where that makes sense from the people's perspective. So it may be that the corporation that's in charge of the service changes, but the location where the service happens might not change. That's for discussion by the operations team and the finance team to say what makes sense from that perspective and then cost that out. So I wanted to go back and just reflect on that. But before I move from here, as people might have had a chance to take a look at this, I'm wondering if there might be any particular questions in terms of understanding how we got here or what something might be. And there will be definitely time at the end of the session as you reflect in case you have some questions. And within your own team too, which will be a smaller team. And afterwards as well, through email to Jennifer, myself, or Cynthia.
I'm just looking at LLG, right? Because that's what they interest me, or that's where my interests are. There's a couple of fairly significant services that are not included on there. For instance, DDACT, which is housed at Royal Ottawa Hospital, as well as a psychogeriatric team that serves our area that is not out of Kingston. So I'm just wondering about inclusion of those.
Very good question, and I didn't read the fine print on the bottom here either, so I'll come to that as well. But that's not on the fine print, and that didn't come up during the RTF discussions as well. So as a first step in that discussion, we have a meeting scheduled with our colleague Champlain Lynn to initiate a discussion to make sure, they've been aware of what we're doing, but to formally start the discussion and gain the understanding around our redesign and our redesign process and what our thinking is like. And once we've had that conversation with the Champlain Lynn, then it would be broadening perhaps some membership on some of the teams to have the conversation and how that would look. But so that's definitely there. The other points on the bottom, mental health support network. We have right now in this model, working model, continuing to hold an accountability agreement directly with Berlin and serving the entire region. And other children and youth and CCAC services are not reflected in this diagram right now, and that is something that we can work towards. But we wanted to get really the core items dealt with first, but that's good. And there'll be time as we move forward. So, how are we going to do this? So, some of you may have had a chance to participate in webinars that we had held a little while back, and some may not. And I appreciate your time today in reviewing some information you may have seen before. But we thought it was really important to reset ourselves as we enter this next phase. And that's why we had Jennifer go through the individual experience and the common service elements, because that's our core. That's what we're designing from. And that's what we have to keep touching base on day in and day in. But what are some of the planning principles that we have used to first design this future state, and that you may find your facilitators and your groups coming back to from time to time to remind ourselves as we maybe get down a particular path? The first is ongoing engagement with clients, patients, caregivers, and residents. We have the benefit of a number of client, family, caregiver representatives on some of our design teams right now, as well as a client advisory group that will be helping us to stay true to our vision that we originally initiated. Ongoing stakeholder consultation and feedback. Excessive amounts of information, transparency throughout. You'll see a little bit later how that's defined and what that means in terms of actions of your teams. And opportunities for you to inform other teams' work, and for your colleagues who are not here today to inform all of our work. Ongoing engagement in particular with Francophone and the Indigenous community. We have a representative from Réseau, who is our planning entity along with the Champlain region, on the project team, and there will be some documentation available to each of you to consider on your individual team. And we also have a representative from the Indigenous group, in this case the Mohawks of the Bay of Plenty, who will be on the project team as well, helping to inform our design as we move forward. There is a steering team and a project team, and those two teams at a governance level and administrative level will keep us all connected and make sure that if there are opportunities to build on each other's work, that we do that, and then we don't end up going in separate paths inadvertently. And then we deal with the risks that arise through any kind of big change. There will be also special consideration, and that's the second last bullet point. One of the things we learned through the first part of this redesign work was the need to consciously ensure that both addictions and mental health have an equal representation in this design, so that one doesn't inadvertently overwhelm another, and that's really critical. And this is really a phrase used here is an appreciative inquiry approach. When you're at your table, we really want everybody's perspective and creative energy to build something new and not be constrained by what was, but really give yourself permission to be creative within the parameters we've been given by the individual experience. So we did learn quite a few lessons through the first phase, and we're trying to make sure we don't have to relearn the same lessons through the second phase. A lot does need to happen, but we do need to keep looking forward. There is a tendency sometimes to look back and what's happened in the past, and we definitely have to learn from that, but not have it stop us in our progress in achieving that individual experience for our clients and caregivers. We need to provide time. So this is one of the last talking at you sessions. The rest of the sessions will be team discussions. And that's one of those things that we learned. With a lot less presentation, a lot more space for conversation, because that's the purpose. And so this will be one of those last more one-way sessions. And if the client voice, we say the client voice is going to be the center, we actually need to include the client's voice, not just in the diagram, which is a very critical diagram and it will be in every meeting, but through actual experience And that's why the Client Advisory Committee, and that's why we have representatives on the teams as well. As well, one of the other things we learned is our governors, our board members need to be included all along the way, not at the end of the process. This is very much something critical from the board members who are right now responsible and accountable for the individual agencies and delivering on the mission for clients. They need to be part of this every step of the way. And we have a governance team to ensure that, and we also have governance representation on the steering team. The structure, so you see it looks a little heavy, but we're doing something really, really big and I think amazing at the end of the day. We have a steering committee which will report directly to the board of the Southeast Wing. So there's no filter, as it were, through administration. It's a direct communication. We also have the project team. So that's the leadership group that will keep everybody on the same path. You see each of the planning teams below, and you are members of these teams. Over on the left-hand side here, we have a client advisory group, feeding and guiding directly the project team. So the leadership group receives advice ongoing from the client advisory group, and our communications team supporting all of this. There are roles for each of the committees, and there will be detailed terms of reference and specific deliverables that you'll see at the kickoff of your launch meetings next week. The steering committee and the project team aren't yet named. All of the members are not yet named to those committees because for the project team, we need to have each of the planning groups identify a chair. The chair of that planning group will be a member of the project team. I'm also going to ask at the end that amongst all of the members, and we'll have a process where this can happen, that we have someone nominated to be a co-chair of the project team from the field as well. So it will be myself and one of the members nominated. So we'll have a process for that. On the steering committee, there will be a similar process for nominating a co-chair from the field. And we will move forward. So you see, these are very much leadership, administration roles, making sure we're all staying on track to the deadlines, hearing the risks and issues, trying to remove the barriers and help this project move forward. The governance team will be responsible for beginning with the working model, developing the governance and leadership elements, and there is a detailed list of them that will be available to support the final option. The clinical team has the greatest amount of work to do, I'll say, in volume and criticality to the actual delivery of this individual experience at the end of the day. But you also have the benefit of a lot of hard work that's already happened through the clinical services roadmap. So a number of the elements that were identified as key service elements on the clinical team are well down the path of development, and that information will be brought to your team. And they've been developed by the field. So I think that really stands you in good stead on that team, even though your role is big. The Health Human Resources team, that's actually considering the implications for the workforce of these combinations. What do you have to pay attention to? So you'll have some specialty advice as members of that team with human resource expertise and legal expertise, just to talk about the kinds of things that would have to be in place that you have to look at. So when you have multiple unions coming together, what do you have to do? Do you have to do a Public Sector Labor Relations Act application, and what's that all about? So discussing the process, but not discussing the details, because of course you can't get into those kind of details until an actual decision is made, and you know for sure who's joining with whom and when. So, but talking about all the process and the implications and considering what has to happen in the order. So quite a bit of work for that team. The administrative and finance team, get to look obviously at administrative and finance issues, but they're responsible for defining the high-level costs, the high-level benefits of coming together and delivering on this working model. So they'll have a big push of work at the beginning, then they'll have to wait a little bit for you to develop some of your efforts on the other teams to give to them to inform the rest of their work. So they'll need to consider that. But some of the things they'll consider would be things like a common IT system, how close are you now, and what would the implications be? If it's considered that there would be fewer number of locations, what would the implications be on leases, and all of that sort of detail is what they need to look at. We have the operational future state planning team. So how do you actually operationalize this? So whenever a decision is made to do some level of combination, what are the implications? What do you have to actually consider? And how do you manage client load during that time? How do you support the morale of your staff during that time? So those are the kinds of conversations the operational team need to get down into the details of, so that at the point in time where we're able to make a decision, we're very clear about what that's going to look like and how we're going to be able to achieve it. And the client advisory group throughout, receiving the high-level reports of information and progress from all of the teams, and providing feedback, first of all, a test. Okay, is that really still staying true to the vision? You know, is staying still true to the ideal client journey, or what are the implications? You know, if I think, oh, if you're going to do it this way, what is this going to mean in real life to an actual patient, or my son or my daughter? The communications and engagement team here, we're so passionate about the client advisory group, we have no choice. So the communications team will be responsible for supporting each of your teams in communicating your progress, because we want this to be very transparent. So we're not going to wait till the end of the time and then the big release and reveal about what this is. So all along the way, all the progress we'll be making available to everybody. So as Paul said, really concentrated effort. So there's great benefit in concentrated efforts. It's that you get in, work hard, and get it done, but it's a concentrated effort. So that's a pretty intense work period. So each of the teams right now, it says a 2-month period, but we're focusing to the end of June. We're looking weekly, recognizing that occasionally a team may not have the information necessary to deliver, and I talked about admin and finance as an example. They might have to wait for something. But right now our plan is weekly. Every Wednesday we hold all kinds of people and consider all kinds of standing groups and opportunities, and the issue of, you know, after weekend activity and before weekend activity, and we've come up with the Wednesday, trying to also look at late afternoon, early evening, recognizing everybody is very busy. Calendar invites have gone out. The location, Denise talked earlier about confirming the locations, and that will be out tomorrow. She was hoping for a call back before she left today, but didn't get it, so I can't confirm it to you. But they will be in Kingston, because that is, at least the people on the east and the west don't have to drive across the whole thing. For the most part, in person, because in a creative dialogue situation, seeing somebody and what their facial expression is like, and whether something is really bothering them that they don't want to, you know, talk about a particular issue, you can actually explore that if you see it face to face, less so by teleconference. So we really want to minimize that, but do recognize that occasionally there might be an instance, and so, you know, if there is something, if you can speak with Jennifer or your chair lead, we'll see what we can do to accommodate and still maintain that conversation. We will have Lynn staff or KPMG staff to help with facilitation and note-taking to try and minimize that burden on the members of the team and let you focus on the conversation. But we will be asking you to name a chair from amongst the members who's not Lynn or KPMG. We will commit to getting information out to you in advance of your meeting, at least, at worst, 24 hours before, at best, 48 hours before. And each team will have a workbook, and you'll see those workbooks. They'll be coming out, Amanda? Monday. So the workbooks will be coming out Monday, and those workbooks will give you a flavor for, give you a picture for the future. So it won't be a surprise every meeting about what you're discussing, so everybody can get their minds around what we'll be discussing. And it may look overwhelming at first, but it's going to be step by step and building on the last and building on the last. And maybe we can have one of our RTA redesign task force members comment on their experience last time around. Because what we did with them, we've now learned, and we've tried to make this process better. So what is your role as a member? And again, I reiterate Paul's comments earlier. Thank you very much for volunteering and committing to this process. This is going to be a good design because it's being done by the people in the system who work with clients, who have family members, who are clients and have used the system, who govern various agencies. So this makes it a much richer, more likelier to deliver on the client journey design. We want your input, and we want you to represent the client, to bring your client focus every day when you come on Wednesday and when you review the materials in advance. Following each meeting, at the end of each meeting, we will specifically ask these two questions. To what extent did your discussion today focus on the client's needs? And do we need to consider changing